sir.
Okay. So, good evening, everybody. Today, we are talking on a very focused topic of heart failure, that is risk of heart failure hospitalization and the role of sacubitril valsartan. Now, all of us know hospitalization for heart failure is the most distressing feature in the natural history of heart failure because every hospitalization, every rehospitalization takes the patient closer to death. And every hospitalization is an indicator of progression of the disease. It decreases the quality of life, and finally, the patient succumbs to death. And this is elegantly shown in this slide that hospital readmission leads to higher mortality. The one-year mortality rate is significantly higher in patients who had more than one hospital readmission. On the top, you can see there's more than one readmission, and in the red, you can see no readmission. Clearly, you can see the mortality is higher in those patients who are admitted again and again in the hospital. And one hospitalization increases the risk of death 3 times. And this is again very elegantly shown in this slide. The more are the number of hospitalization, the more the patient is moving closer to death. And therefore, the big message in management of heart failure is prevent hospitalization for heart failure, prevent rehospitalization for heart failure, and indeed, sacubitril valsartan is powered to do it on top of standard triple therapy for heart failure. Now let's look at this data on heart failure. All of us know in the West, heart failure is one of the most common causes of hospitalization for patients aged more than 65 years in the developed country, and India also. This is a very common cause. The in-hospital mortality of acute decompensated heart failure is very high, 7 to 10%. 30% are admitted within 6 months, and 44% of all heart failure patients are readmitted for any cause within a year after discharge. The length of stay is usually 5 to 7 days, and treatment becomes more and more expensive as hospitalization and rehospitalization increases and poses a great burden on the patient, the society, and the nation. And this readmission, as you can see here, is similar across the gender, is similar across the ejection fraction, and 1 out of 3 patients readmitted at least once over 1 year. And one of the most important causes of rehospitalization is, or hospitalization is, suboptimal guideline directed medical therapy. And if we look at the statistics, 25% received this guideline directed therapy. So there's an urgent need to bring more and more patients under the net of GDMT so as to minimize hospitalization for heart failure. And the mortality will go on increasing as time passes in heart failure. So we need better strategies to improve the outcome of patients of heart failure, so that if a patient is hospitalized for acute decompensated heart failure after hemodynamic stabilization, the current message is, the current strategy is, initiate sacubitril valsartan if the patient is not on ACI or ARB right from the word go. If the patient is on AC inhibitors, wait for 36 hours washout period, and if the patient is on ARB, you can change ARB to sacubitril valsartan, and this strategy we'll see is superior to the conventional strategy of ACI ARB. And there's no need to titrate ACI first and then switch to sacubitril valsartan. And NT-proBNP or other marker levels are not at all required to initiate this therapy. So let's see what is the data available to initiate these therapy in patients with ADHF. We had 2 landmark trials, the transitional trials and the pioneer HF trial. And the transitional trial attempted to initiate sacubitril valsartan in hospitalized patients with HFrEF after hemodynamic stabilization. And this is very, very important, because We know the prognosis after hospitalization ADF remains poor, especially within the 30 days of discharge. So if this therapy can be initiated prior to discharge or early after discharge, this is going to be very fruitful. Now, this is the design of the transitional strategy. You can see there's a pre-discharge initiation, which is 24 hours after the hemodynamic. The other strategy was post-discharge initiation, and the strategy is same. If the patient is on AC inhibitor, you have to wait for 36 hours washout period. If it is not on AC inhibitor or ARB, you can directly start Sacubitril valsartan in increasing doses. If the blood pressure is maintained 100 and then 200, otherwise if it is lower side, 50, 100 and 200 BID. And let's see the results. Now, the primary objective of the study was to evaluate the proportion of patients achieving the target dose of Sacubitril valsartan 200 mg BD at week 10 post-randomization in both the strategies, pre-hospital and pre-discharge and post-discharge. And the secondary endpoint was how many percentage of patients achieved and maintained the dose of Sacubitril valsartan 100 or 200 mg BID for at least 2 weeks, leading to week 10 after randomization. And the other secondary endpoint was what percentage of patients achieved and maintained any dose of Sacubitril valsartan at least 2 weeks leading to week 10, and what was the number of patients who discontinued therapy during this 10-week period. And let's look at the results. The primary endpoint, you can see roughly half of the patients in each group achieved the target dose, whether it was started pre-discharge or post-discharge. And if you look at the secondary endpoints, so the percentage of patients who achieved 100 milligram or 200 milligram BD, you can see roughly 63-64% achieved this. And the percentage of patients who achieved any dose of Sacubitril valsartan is 86-87%, and negligible number of patients discontinued the drug. And you can see Sacubitril valsartan up titration does not prevent initiation or up titration of the guideline directed therapy, that is beta blockers and MRAs. So the conclusion of this study was comparable proportions of patients met the primary and secondary endpoints in the pre and post discharge initiation groups. About half of HFrEF patients stabilized after an ATJ event, achieved the target dose of 200 milligram Sacubitril valsartan PID within 10 weeks. And at week 10, more than 86% of patients in both the groups were receiving any dose of 2 weeks or longer. The incidence of adverse side effects was negligible. So the strategy should be if a patient of ADHF is admitted after hemodynamic stabilization, it is preferable to initiate in the hospital, or if there are some problems shortly after discharge, and that will give a lot of benefits. So what is the role of Sacubitril valsartan in ADHF? And this is the second trial, Pioneer HF trial, which laid the foundation stone of Sacubitril valsartan for ADHF treatment, is approved by the guidelines in 2019. This is the design of the Pioneer HF study. You can see is a multicentric, randomized, double-blind, double-dummy parallel group. We tried to compare two strategies. In one arm, it was enalapril with maximum dose of 10 milligram BID, and the other arm is Sacubitril valsartan. And if the patient was an AC inhibitor, you have to wait for a 36 hours washout period. And what was the primary endpoint of the study? Time average proportional change in NT-proBNP from baseline. The secondary objective of the study was change in the NT-proBNP at week 8, natriuretic peptide system activation, cardiac fibrosis remodeling judged by soluble ST2, and tissue perfusion injury judged by high sensitivity troponin. And these are the exploratory objectives, which means change in the NT-proBNP at week 1 and 2, time to first occurrence composite of death, hospitalization for HF, LVAD implantation, listed for cardiac implantation, unplanned emergency department or office visit requiring IV diuretics, and increase in the diuretic dose more than 50%. And the safety endpoints are usual. Incidence of worsening renal function, hypotension, hyperkalemia, and angioedema. And this is the strategy how one tries to build up the dose of Sacubitril valsartan. If the blood pressure is more than 120, You can directly start with 100 milligram BID and progress to 200 milligram. If the blood pressure is between 100 and 120, you can start with lower dose, 50 milligram BID, and then progress to higher dose if the blood pressure remains above 110. So these are the results. The primary endpoint, you can see there is a statistically significant 29% reduction in the NT-proBNP with sacubitril valsartan when compared with enalapril, and reduction was evident as early as week 1. So you can see marked an early decrease in the NT-proBNP. And if you look at the serious composite endpoints, which I've already enumerated, death from any cause, rehospitalization for HF, LVAD implantation, or listing cardiac transplant, there's a statistically significant 42% reduction in the serious composite endpoint with sacubitril valsartan compared to, which means it delays the device implantation, LVAD, or even cardiac transplantation. And what about cardiovascular death and rehospitalization? We have 42% reduction in CV death or rehospitalization with sacubitril, and you can see the curve starts very early. After 14 days, you can see the curves are separating and becoming divergent. What about rehospitalization for heart failure? Again, you can see 39% reduction in rehospitalization for HF. The curve starts separating after 14 days. So very, very significant benefit and very early benefit is achieved. Now, if you look at the worsening events, worsening of renal function, not statistically significant, hyperkalemia. Some hyperkalemia was noticed in sacubitril valsartan, and symptomatic hypotension, as we know, is more common with sacubitril. Angioedema is seen in negligible percent of patients if your case selection is good. So how do we titrate and initiate sacubitril valsartan? The criteria is the patient, number one, must have HFrEF. It is not the drug for HFpEF. There should be no history of angioedema. The eGFR should be more than 30. Serum potassium should be less than 5.2. Systolic blood pressure should be more than 100. For the preceding 6 hours, no increase in IV diuretic dose in the preceding 6 hours, no use of IV vasodilator in the preceding 6 hours, and no use of inotropes in the preceding 24 hours, which means the patient has to be stabilized hemodynamically, and then only you should initiate this. And this is, we have already talked that the blood pressure more than 30, you can start with 100 milligram. If it is less than that, you can start with a low dose and gradually build up the dose. So the recommendation before initiating sacubitril valsartan is first dose of sacubitril valsartan must be 36 after the patient last ACI was stopped. ACI may be changed to ARV in this 36-hour period if needed. Clinician should optimize GDMT during this period. Clinician should also monitor for hypotension, hyperkalemia, and worsening renal function and angioedema. So let's discuss this case. Mr. Pratik, 60 years old male, a known case of HFrEF. As you can see, the ejection fraction is 23%, admitted in the hospital, breathless on slight exertion and edema. Ejection fraction 23%, blood pressure 120/70, NT-proBNP 1766 picogram per ml, and serum creatinine is 1. He was already taking the optimal dose of ACE inhibitors, beta blocker, MRAs, and diuretics. Now, faced with such a situation, you must remember that 1 out of 3 patients are readmitted at least once in over 1 year. 1 year mortality is significantly higher in patients who had more than 1 hospital readmission, and 2.8 times increases of mortality. Suboptimal GBT increases the risk of mortality. So such patients who are taking ACE inhibitors or ARB, they should be shifted to sacubitril valsartan after hemodynamic stimulation. And initiation of this is very well documented in the trials which I have shown, unlike other agents where there is no documented data. So can initiating this strategy improve the clinical outcome? The answer is yes. And here you can see a reduction in sacubitril valsartan, a reduction in NT-proBNP by 29%, statistically significant. What is very striking, every curve separates very early. Within days, 14 days, you will see all curves. So sacubitril valsartan, CV death and rehospitalization, again you can see is separating very early, a 42% significant reduction. And whether it reduces serious composite endpoint, which we have already talked, Again, you can see after 14 days, there's significant separation of the curves, and there's a 42% reduction in the serious clinical. And you can see worsening renal function, hyperkalemia, symptomatic hypotension are not big issues, and angioedema also. So the recommendation is sacubitril valsartan rather than ACE inhibitor ARB may be considered in patients hospitalized with new onset HEF or decompensated CA to reduce the short-term risk of adverse events and to simplify the management by avoiding the need to first titrate ACI and then switch on to sacubitril valsartan. This we have already talked about. So the recommendations before initiating sacubitril valsartan, the first dose should be 36 after cessation of ACI, otherwise you can have angioedema, and ACI may be changed to AR with this 36 period if needed, and you should have GDMT, continue to try to optimize, and you should monitor usual side effects, which I've already enumerated. So in hospital ADGF patient like this, you will have several benefits. Sacubitril valsartan will reduce CV death and rehospitalization. It will reduce NT-proBNP levels and offers good safety profile. So the big message for sacubitril valsartan is don't forget every hospitalization, every rehospitalization takes the patient closer to death. Prevention of hospitalization for HF is one of the most important goals in the treatment of heart failure besides decreasing mortality and improving the quality of life and reverse remodeling. Thirdly, sacubitril valsartan is powered to decrease hospitalization for HF, decrease mortality, improves quality of life, reverse remodeling on top of guideline-directed based conventional therapy or beta blockers and MRAs, and sacubitril valsartan should be initiated in patients admitted with HEF prior to discharge or early of discharge, and I've already talked to you about this study. Thank you very much for your kind attention.
Answer. Respected delegates can ask the question by unmuting themselves, or they can type their question in chat box. Sir, there are few questions in chat box. So with your permission, can I read these questions?
No.
Sir, one question is there from Dr. Asa Murthy from Chennai. Dear Dr. Manoria, sir, how long to continue despite normalization of ejection fraction?
The issue, some patients like peripartum cardiomyopathy or patients of myocarditis who have LV systolic dysfunction, they may gradually improve. And the question therefore arises whether these therapies can be de-escalated or stopped. The issue is you should never de-escalate even if the ejection fraction becomes normal, or if you want to have this strategy, at least the GLS should be normal. If both GLS and ejection fractions are normal, then only you may attempt. But sometimes it is seen when these therapies are discontinued or de-escalated, patient does not respond in a similar manner as he was responding prior to de-escalation. So de-escalation should be very careful. Usually it is not advisable. Only these are the two conditions where it may be thought of, but GLS is mandatory. Without the ejection fraction can return to normal, yet GLS can be low. So de-escalation in these two conditions, never do with normal ejection fraction. You can have substantial LV systolic dysfunction. Otherwise, most of the other disease like coronary artery disease or dilated idiopathic cardiomyopathy, the question of de-escalation does not arise.
Thank you, sir. Sir, one more question asked by Dr. Asa Murthy from Chennai. Which is safer when there is chances of hyperkalemia?
Now, whenever we use ARNI, if the patient is having heart failure, or if he is having associated CKD, which is not uncommon, there is always a potential for hyperkalemia. So that right from the word go, you should advise the patient to do all strategies, including diet and others, which minimize hypokalemia. And under these two circumstances, we always prefer eplerenone compared to spironolactone. The reason is, if the patient develops hyperkalemia, you stop spironolactone, it takes 4 to 5, 6 days for the drug to be washed out of the body. But if you take eplerenone, gets washed out 12 or 24 hours. So in the event of a hyperkalemia on stopping drugs, the probability of returning to normal potassium level is many times more with eplerenone compared to spironolactone. So that is the reason why, if we think there's an anticipation that the patient is going to get hyperkalemia, otherwise you always know there's a cross connect between heart failure and kidney failure. If you have heart failure, you invariably get kidney failure. If you have kidney failure, you invariably get heart failure. That's why we never talk of treatment of heart failure separately, treatment of kidney failure separately. We always talk of the cardio-renal continuum. So even if we are discussing an RNA, we have to look at the kidney. If you don't take care of kidney, your heart failure patient would not improve. And if you are treating CKD, you don't take care of your heart. It is a continuum, and cardio-renal continuum is very well known. Unfortunately, this is not simultaneously targeted many times, but I'm sure in times to come with better knowledge and better understanding of the continuum. So even if you are treating heart failure, you have to look at the kidneys.
Moreover, sir, the chances of hyperkalemia is less with the sacubitril valsartan, because sacubitril is responsible for modulating the potassium homeostasis, and therefore chances of hyperkalemia is less with RNA as compared to RAS blockers.
Thank you, sir. Sir, one more question is there. As a cardiologist, how you see the importance of SGLT2 in the patients of heart failure instead of RNA? Will SGLT2 help to improve the ejection fraction of patient?
See, we have 4 therapies: ACE, ARB, /RNA, beta blockers, MRAs, and SGLT2. The current concept is all these 4 drugs must be on board within a period of 4, 6, or 8 weeks, because each drug shows incremental benefit on top of that. So our aim in heart failure, which has a malignant progression, very high mortality, 5-year mortality in a non-diabetic 50%, and diabetic is 85%. So we will always like to have all these 4 drugs on the board. The sequence of initiation may vary, and this historical initiation should never be followed, that AC inhibitor ARB come, you have to initiate then, and then beta blockers, and then MRAs and SGLT2 inhibitors. Any drug can be initiated first, depending on the subset of the patient and the circumstances. If you have a hyperkalemia, low GFR, we would like to initiate an SGLT2 first. If you have problem of blood pressure which is lower, again SGLT2. If your blood pressure is very maintained, the potassium is not an issue, we initiate RNA first. But we will like to initiate all these 4 drugs. And it is seen that if you initiate all these 4 drugs, the projected survival is increased by 4 to 5 years in times to come. And this should be the stage. De-escalation, you should never think of de-escalating therapy in most of the patient, because the cause is not reversible. And never forget, heart failure is never a stable disease. Today you are all right, tomorrow you may not be there. Sudden cardiac death can kill you, or you can have hospitalization for heart failure without any warning symptoms, because apoptosis continues, and this is evident by slow persistent elevation of CNT, cardiac troponin. You measure in these patients, they are elevated at low level and they continue to remain. So heart failure should never be stable. On all patients must be on all these 4 strategies for HEP-REP. Usually the patient thinks, or the attendant thinks, that why you are giving so many drugs. I think the patient should be explained as we explain them in malignant conditions, even acute myocardial infarctions. For example, in acute myocardial infarction, you have to take antiplatelet, you have to take anticoagulant, you have to take a lytic therapy, PCI is not available, and you have to take AC inhibitors also. So combination therapy is mandatory in HEP-REP because the mortality is very high, and the attendants and the patient should be convinced that you have to take multiple drugs. If side effects develop, patient is not able to afford, that is a different state of affairs. And SGLT2 drugs can be started right from stage A, B, C, D. ARNI can be started, BC, and also in D, stage D, separate trials are ongoing. So all these drugs should be started early in the period of heart failure. So to have maximum, rather trying to use ARNI or SGLT2 very late, if you use them late, the benefit is less. But unfortunately, Indian statistics shows ARNI, I think 15-20% is the figure. So it's still highly underutilized in our country.
Yes. Yes, sir. Panjolia, sir, can we get your view on this regarding SGLT2?
No, see, now SGLT2 is now important pillar of the management of heart failure with reduced ejection fraction. Initially, we used to say there are 3 pillars. Now there are 5 pillars, including ARNI as well as the SGLT2 inhibitor after the recent trials of DAPA-HF and now the EMPEROR reduce. So they all clearly showed a substantial reduction in the CV mortality and heart failure hospitalization. So it is an important and welcome introduction in the therapeutic armamentarium of HFrEF patients.
Thank you, sir. Sir, one more question is there. Role of ARNI in HFpEF. Is there any role, sir? Asked by Dr. M.C. Agrawal.
HFpEF, the Paragon trial was negative. Only 2 subsets of patients benefited. Females, they had a reduction by 27% hazard ratio. And if you look at the ejection fraction, it was 50 to 57%, there was a benefit. But this is a subgroup analysis to be tested in future trials. But what I want to say is that the definition of HFpEF and HFrEF based on ejection fraction is still severely questioned, because ejection fraction is not the sensitive indicator of measuring systolic function. 25% of HFpEF has diminished GLC, indicating that 25% of HFpEF, which you believe the ejection fraction is normal, that systolic function is normal, is a misnomer. 25% have LV systolic dysfunction, and we know JELS is very well validated even in the cardio-oncology, now coming to valvular heart disease. So that should be the way how to, and then you cannot have a fixed cutoff point, HFrEF and HFpEF, it is 40, 30.9, it is HFpEF and it becomes more than 40.1, it becomes mid-range, and it is a continuum. Most of these patients of HFpEF have both these features. So systolic dysfunction, HFrEF has HFpEF features and HFpEF is usually a spillover. So these trials which are trying to take strict cutoff points, I think, is not appropriate. Even in the Paragon trial, you see 50 to 57% is showing benefit. So the criteria for judging HFpEF and HFrEF needs revision, and ejection fraction is no longer the most sensitive index for categorizing heart failure. I am sure in times to come, the categorization of heart failure will be more by GLS rather than, because we know 25% HFpEF has impaired GLS.
And GLS is important predictor of the outcome also in these patients rather than ejection fraction.
Even in patient with valvular heart disease, we know that if the GLS drops, aortic stenosis, you have to submit the patient to surgery. Even mitral regurgitation, if the GLS is dropping, you have to submit the patient to surgery.
Even for the cancer chemotherapy also, so which patient will land into the problem, it will be decided by GLS. When it is less than 16%.
Oncology, it is the way to go.
Thank you, sir. Sir, one more question is there. How to initiate ARNI in heart failure patient with CKD? I
think if the usual guidelines say the eGFR is 30 or less than 30, you should initiate. But I think because heart failure itself can kill the patient rather than kidney disease. So what do we do if you have a GFR say 30 round? What we do, try to decongest the heart by drugs which do not affect the creatinine, which means you can use hydrogen with nitrates, you can use IV vasodilators, you can put the patient on balloon pump, who is a patient of acute myocardial infarction or acute. And when the heart failure gets stabilized, the ejection fraction improves and the kidney function also improves. So many times we see when we adopt this strategy, we are able to initiate ARNI by deloading the left ventricle, and we deload the ventricle even with inotropes and vasodilators, because the stroke volume increases, the cardiac output increases, the blood pressure comes up. So usually we'd always like to initiate even in the borderline range of eGFR, and this is the strategy we adopt, because many of these patients will pop up because of left ventricle failure. So we will always like these patients to have. And if you are working in a dialysis center, I think things can be used more safely, because sometimes it can produce acute kidney injury, and hyperkalemia is a problem. We have said to minimize hyperkalemia, dietetic restriction should be told to the patient, and when these binders, newer ones, epetramer and others come, you will be able to treat hyperkalemia and initiate ARNI in those patients of CKD who have hyperkalemia. So this is the strategy which we adopt in patients with CKD and heart failure. Because if you improve heart failure, CKD improves. Don't forget that. So you should not keep quiet. eGFR is 30. ARNI cannot be initiated. You have to make attempts. You have to make modifications in your treatment to improve heart failure, so that kidney flow increases, eGFR builds up. Because all these are dynamic things. eGFR 30 doesn't mean it will always remain 30. Heart failure, because of diminished renal flow, eGFR also decreases.
Thank you, sir. Sir, question is there. One more question is there. Can we use ARNI in chemotherapy-induced LV dysfunction?
The data is not available, but it's quite logical that it will benefit. We don't have any dedicated trials of ARNI, but because you are using in all systolic dysfunctions, but there's no data to the best of my knowledge for any trial.
Yes, sir. Sir, one more question most of the time asked by the physician, because NYHA class 2 non-symptomatic patients first go to physicians. So what is your opinion regarding starting ARNI in non-symptomatic patients?
You can dramatically change the outcome of asymptomatic left ventricular dysfunction. You have asymptomatic left ventricular dysfunction, you can start ARNI, you can start SGLT2 inhibitors, you can beta blockers. All therapies should be initiated. Maximum benefit in heart failure is stage 2. Stage 3, the benefit decreases. Stage 4 is still minimal. So if you are picking up asymptomatic LV systolic, please initiate AC inhibitors, ARB, ARNI, whatever is available, whatever the patient can afford, beta blockers. It has to be treated as heart failure. It has already gone stage B heart failure. We should try to prevent heart failure rather than treat, so that even if you have risk factors stage A, you should try to control all these risk factors. And some of these drugs also modify this. For example, SGLT2 decreases weight, decreases diabetic, glycemic control, decreases blood pressure. So the current dictates you can start SGLT2 right from stage A, because it modifies the risk factor. So anything which modifies the risk factor can also. But stage B, all these therapies become mandatory, because once the left ventricular dysfunction sets in, it runs a malignant progression. The earlier you tackle it, the more life will be prolonged. The later you tackle it, the longevity is decreased. So asymptomatic LV dysfunction is an absolute indication for all heart failure drugs. And all trials have shown the benefit is more in stage 2 compared to 3. As you pass on to stage 3, benefit is less. In stage 4, the benefit is much less.
In the paradigm HF trial also,
does not mean that you don't initiate these therapies. Is the greatest misconception in heart failure. No symptoms in LV dysfunction, don't initiate. You should initiate. There may be reluctance from the patient, but you have to explain, because patient feels I am asymptomatic, why you are giving me so many drugs.
Thank you, sir. Pancholia, sir, can we get your opinion?
Yes, I fully agree with Dr. Manoria. You have to start in the stage 2, because in the paradigm HF trial, with the sacubitril valsartan, majority of the patients were of the stage is the NYHA class 2 and 3. 70% of the patient in class 2. So it is to be initiated early in this, in order to prevent the progression of heart failure.
Thank you so much, sir, for clarity. So, sir, since there are no more questions, so on behalf of Novartis, I would like to give great thanks to Dr. Pancholia, sir, Dr. Manoria, sir, for their wonderful and insightful session and giving clarity on the questions and misconceptions. So, thank you so much, sir, Pancholia, sir, and Manoria, sir. And we would like to also thank all the delegates who have taken out time from their busy schedule for this session. Thank you so much, sir.
Okay, bye bye, Dr. Panchulia.
Yeah, thank you, sir. Thank you very much, sir.